Hey there, how are you? Wanted to talk about how to differentiate what a rotator cuff injury is as opposed to a different shoulder injury. So, brief introduction. My name is Dr. Erickson, physical therapist, owner of VHS Physical Therapy Chiropractic, as well as the Herniated Disc Fix and Challenge Wellness. So, common complaint, or at least idea of complaint of, hey, I have a bad shoulder, my arm or shoulder hurts, it's probably my rotator cuff. Well, in actuality, we're going to go through that and kind of figure out, help you funnel down and critically and mechanically think through this and see if really it is a rotator cuff injury or is it possibly something else. And as we kind of done this for many years, and as the research will show, that it's more than likely that it's not a rotator cuff. At least 50 to 60% of shoulder pain comes from the neck anyway. So when you start thinking about that, plus other things that could happen inside the shoulder, the chance that it's truly a rotator cuff problem, and that's what's causing the pain, is a little bit lower on the scale of probability. Let's go ahead and show you what the rotator cuff looks like. All right, so here's a picture of what the rotator cuff would look like from the front side here. So you've got a couple of ones that come in from the front, all right, and this is on the top. So supraspinatus, and then your infraspinatus, your teres minor is kind of small, and then the big guy here, subscapularis, helps bring the arm in. So this one, the supraspinatus and the infraspinatus are ones that can be involved, but they all come together like a bed sheet. So don't think of them like these ropes, like this is a bicep. It's not like a tendinous rope. It's more like this right here, where you have this kind of a length, and it's a wide sheet. And so you can have little tears in there, but overall, the thing could still function and work. Even if you had a hole in your shirt or a hole in a blanket, the blanket or shirt still works, there's just a hole in it. So there's other fibers that can still pull through there. So now let's go back and talk about the difference between how we'll know whether it's rotator cuff driven or if it's something different. All right, so now that we've kind of taken a look at how the rotator cuff muscles turn into tendons and how that tendon attaches into the shoulder, and like I said, it's more of like a shirt or a sheet. It's not necessarily four individual strands or ropes. Let's talk about how you'll know if the pain that you're experiencing is truly caused from the rotator cuff. So the thing we have to think about is when a pain is driven due to a muscle or tendon, which is what the group of the four rotator cuff muscles are. They're muscles and tendons. Muscles and tendons move bones, and they activate during active motion, and they'll hurt worse with increased load. So if I have a problem on my right shoulder that is truly a rotator cuff problem, when I actively move my shoulder against gravity, that should cause pain, right? Other things can too, but we're just going to kind of, let's funnel this down. So this will cause pain when I move it. I should not have a loss of motion. Like if I really can go, it hurts, but I can go all the way up, so I wouldn't lose motion. There'll be pain there. And then if I add load to it, if I have increased weight, that should hurt more because I'm calling on more of the fibers to contract and more of that muscle and tendon to do its job, okay? So increased load should hurt worse, all right? And then the consistency should be very consistent. Every time I do that, it should hurt. It can't be where, well, some days I can raise my arm up with no pain, and then some days I raise my arm up and it has a lot of pain. That would not be consistent. If a muscle or tendon is torn, every time you activate it and you want it to shorten and contract, it's going to hurt. Or if you contract it as it lengthens, which is called eccentric. So if you had weight up here and you tried to lower something down, it's just going to feel like it's going to drop. That would be, and it'd be consistent. It can't come, sometimes you have strength and sometimes you don't. Okay? So we talked about there'd be no loss of passive motion. Like if I lift my arm up, I should be able to go all the way. If there's some kind of block where it just won't go, that's not typically consistent with a muscle or tendon tear or injury like a rotator cuff. So a loss of motion or a block sensation or some kind of inconsistency, right? Sometimes I can move it, sometimes I can't, sometimes it hurts, sometimes it doesn't. That's not consistent with a rotator cuff problem. The other thing would be the ability for the pain to decrease with passive motion as compared to active motion. So if I actively raise my arm against gravity, right, so I'm calling on my tendons, my muscles, to do the work, which is going to hurt. If I use my other arm, or if somebody else picks my arm up and takes it through that same range, it should not hurt, at all or nearly as much, very little, because I'm not using my muscles shortened to lift it up. It's just the joint running through its motion on its own. So that's a very big one. If you have the same amount of pain passively as you do actively, that's speaking to something else probably inside the joint, or maybe back towards the lower cervical spine. So inside the joint, it could be something with the labrum. It could be something with the actual, like the surface of the joint, the cartilage surface. So it could be a little derangement or something caught in there. The other thing would be the location of the pain. So these are some of the questions that we will ask when someone comes in. They're convinced they have a rotator cuff problem, when in more than likely, or most of the time, they don't. So location is very key. So it has to hurt kind of out in this area on the lateral side and very point tender over top, where those tendons attach or where they insert to. Now, occasionally, it will radiate kind of down into the upper part of the arm, but again, that's just part of the information. Then we'd start looking at it actively versus passively. Actively with more load, does that turn it on even more? Does it just feel like it's going to drop? The other thing we talked about, consistency, and then the difference in pain versus active and passive. So, and then the last thing, so let's go back to location. So if location is, no, I feel it like in my trap, in my shoulder blade, and it goes down the arm, well, that is probably not rotator cuff related. That's probably more lower cervical spine related, which at least 50% of shoulder and arm pain is due to that and not the rotator cuff. So we have to look at that first. The other thing that's important is when you feel the pain. So this kind of goes back to that consistency part. If you're saying, no, I can do stuff. If I'm active, if I'm moving and I'm doing stuff, that doesn't really hurt. It's when I sit down, at night and I'm relaxed and I'm not really even moving my arm, I'm just watching TV, or I'm just, my arm is like sitting here and I'm driving and this arm just starts to ache. So if it has to do with inactivity, if you're getting more pain with inactivity, then it's most likely not due to a rotator cuff injury. Okay, so then we take that information. So think about all those. Think about your day, when it turns on, how consistently it turns on, the motion, the load, all those things. And then you still, even if it's matching up, you would still want to at least start with assessing the lower cervical spine, where you'd want to first take a baseline first. Okay, pain. I have a little bit of a painful arc, right? It hurts that way, and then check this out first. You want to sit hips all the way to the back, nice and tall. You're going to work into this arm can actually stay relaxed. This is my bad arm, so we'll go retraction, extension, all the way back, far. Now, if doing that reproduces your pain, your symptom in that location, and you're not moving your arm, then it's absolutely not a rotator cuff problem. Even if something shows up on a scan, an MRI, a CT, whatever kind of advanced imaging you've got, it was probably always there. If you were an active person when you were younger, throwing baseballs, footballs, heavy work, pushing and pulling, weightlifting, you're going to have, the chances you have some kind of rotator cuff tear are very high. 90% are going to have some kind of tear. But just because it's there doesn't mean that it's actually the pain producer. So if I'm not moving my arm and I can turn this pain on with neck movements, the origin of the pain is back here. So we always start this way, because like I said, 50%, half the people that have this problem, that have pain in the arm or shoulder or in through here, have a lower cervical problem. So that is way too high of a presentation to not really dive in deep and look at it. So we're going to start this way, here, back, far. And so the key was, if it turned it on when doing that, we know it's not rotator cuff, it's got to be neck. Let's just say it doesn't turn it on. You don't feel anything, like I don't have any pain now. I do this, I don't have any pain. It doesn't hurt me at all, it doesn't do anything. Okay, keep going. Do a set of 12, 15, right? 20 of those, back, far as you can. And then retest. So now all of a sudden, if you get up and you're saying, oh, that moves easier, it feels freer, or more free with my movement and I have less pain. Again, probably more due to a neck or a shoulder or a deeper inside the shoulder. Actually, with that one, just a neck issue. We'll go through the shoulder ones in a different video. But this is just to help you differentiate and at least have an idea of, is it possibly shoulder or is it more likely neck, all right? So the other way would then be to go ahead and take a weight again, and if you feel like, no, it doesn't hurt as bad, to lift an increased load. I can do this easier with less pain after doing that retraction extension, then it is not a rotator cuff issue, and it's a neck issue, and we gotta treat that differently. Now, let's go ahead and say, well, that movement didn't affect me at all. It's the exact same. I fit all these criteria. I have increased pain with increased load. I don't have any loss of motion. It's very consistent. Every time I do this, it hurts. When I leave it alone, it doesn't hurt. When I rest it, it's fine. I have no loss of motion. The location all fits. Okay, so then it very well could be a rotator cuff injury. If you meet all those criteria, then it's consistent with probably a rotator cuff, tear, strain, more of a tendinopathy. We're finding more and more that it's not actually, unless you like pick something up and like right away, like when you picked it up and it popped and it was instant pain and your arm dropped, okay, that's an acute, like we're pretty sure that's probably what's going on there when you have a mechanism like that. But if you're not sure how it started and you can't think back to how or why your shoulder hurts, it just started, we have to dig first deep into the lower neck, then deep into the shoulder with different repeated movements behind the back, extension, adduction across. If all of a sudden moving it a certain way makes it feel better, then it's a deeper joint problem and not a musculotendinous problem. The musculotendinous problems will be like we talked about earlier. They'll be very consistent with their presentation and what turns them on, what turns them off. Rest will be fine. Motion will hurt. No loss motion. At end range, you can get all the way. No loss of any kind of motion. And then the location will be right. So that is kind of how we determine whether or not your pain is really due to a rotator cuff injury or something different, a different shoulder injury inside. Like I said, an internal derangement due to a piece of labrum, a piece of cartilage, a piece of fat, a different kind of injury, or a lower cervical injury. So even in like stark contrary, right, to if you had an image, say, well, you went to the primary care doctor, my shoulder hurts, of course, they're gonna take an x-ray, yeah, you've got some arthritis, they're gonna take an MRI, okay, you've got a rotator cuff tear, now you're scheduled for surgery, you still need to, assess this thing and get some treatment, because if we can save you from a $30,000, $40,000 shoulder surgery that you didn't need, and by the way, won't even really, if it's not coming from the rotator cuff, it won't help you, you're still gonna have pain even after the surgery's over. That's important, that's very important. It's what we, are here for, is to help you differentiate and decide and help yourself and not go through, unnecessary medications, unnecessary injections, unnecessary surgeries when you don't have to. Okay? So those are the main criteria for a rotator cuff musculotendinous injury versus something else. So because the research is showing that it's more likely that it's something else, a lower neck, a deep shoulder, like inside the joint problem, and then it's less likely to be a true, rotator cuff problem. But even if it is, okay, only a small percentage of those would need surgery, and the vast majority of those that are true rotator cuffs will remodel and respond to progressive loading of that, because it's a tissue, because it's a tendon and a muscle together. When you progressively load that over time, and with the correct amount of loads and increasing it slowly, your body will remodel and scar down that bit of tear, and you'll have a good outcome most of the time without surgical intervention. But you have to know that's what it is. Otherwise, you're loading a tendon or a muscle and a tendon that's not even the problem. So that's what we commonly see is someone comes in, hey, I've been diagnosed with a rotator cuff injury. What happened? Well, I'm not better. Well, I've been going to therapy. What have you been doing? I've been doing all kinds of rotator, like muscle and tendon stuff. Well, the reason you haven't gotten better is because it's not actually a muscle or tendon issue. It's something else. The ones that are appropriate for muscle and tendon loading, they will do better over time, but it takes a good 6 to 8 weeks of consistent, work on it, consistent loading, And that's the point I'm trying to make here, is you have to be able to subcategorize and differentiate and understand what is truly causing the pain before you can give someone an intervention or a movement or an exercise. You have to know what you're dealing with first. So hopefully that was helpful in helping you to differentiate what is causing your shoulder pain. Is it muscle and tendon? Is it not muscle and tendon? Something else. So if you have other questions, let me know, and I can try to help you differentiate through that process and get you feeling at least on the right path, so you know who to see. So I don't want you to have, spend either 6 or 8 weeks just, hammering away on a muscle or tendon and doing all this rehab and all this work, and it not work, it not help because it was the wrong tissue, or even worse, have a surgery that you didn't need, that didn't help, and now you're just in the same boat. So it's important to differentiate these things and understand what you're dealing with. Okay, join me on the next video. If you liked this video, I would very much appreciate a like, a share, subscribe. That way I can continue to make as many more educational videos for you and help you as much as possible.